Hello, I'm Dr. Jeremy Rogers from NHS Digital, and welcome to this short video on clinical data analytics. The video accompanies NHS Digital's series of interactive hands-on workshops, or hack days, on clinical data analytics. It aims to provide attendees with a quick orientation into the background and goals of the workshops. The workshops were an evolution of the CDAT project, which was carried out in 2014-15. This project was an experiment of opportunity built around pre-existing software called the Data Migration Workbench, which had then been developed into the Clinical Data Analytics tool, or CDAT software. It's a proof-of-principle prototype for SNOMED CT-powered health analytics, and it's the same software that's used in the hands-on part of the workshops. The original project wanted to both test and perhaps stimulate the market opportunity for what I call desktop clinician analytics, and what I mean by that will become clearer later. The project plan had been to find 20 or so hospital clinicians who were willing to donate some of their time, and then provide each with a lone laptop preloaded with an extract of that clinician's own clinical data and the CDAT software, and then give those clinicians a few weeks to directly query their own coded clinical data using the desktop tool, before then evaluating their thoughts and experience. In the event, and for a variety of reasons I won't go into here, this ambitious project was scaled back to a series of 4 half-day workshops, during which around 40 clinicians and researchers were instead brought to the data via desktop sharing, and encouraged to frame and then execute some clinically interesting queries, and then provide their knee-jerk evaluation and thoughts on what they had experienced in the half-day workshop. The main output of the project as a whole was a short report circulated within the Health and Social Care Information Centre and also to existing commercial players and potential players in the marketplace for clinical analytics, some of whom had already stated they were reluctant to invest in developing new analytics offerings until they were more certain what functionality was actually required by clinicians and where the demand for it would actually come from. Although the CDAT project itself ended in August 2015, the response to its half-day workshops was very positive, and so we've continued them ever since in more or less the same format as part of our terminology educational program to support the SNOMED deployment across the NHS. The format of the continuing hands-on hack day workshops, therefore, is a 20-minute introduction to the clinical analytics context as a whole, so this video, a 5-minute basic orientation to the CDAT user interface, a hands-on session in which groups of typically 2 or 3 participants go into a virtual breakout room with the subject matter expert, and each participant then gets to drive the CDAT software under instruction for about 15 to 20 minutes, before exiting into a final short plenary session where we can answer any outstanding questions, share experiences, and then invite participants to complete an online evaluation taking about 5 minutes before finally closing the meeting. So where did all this begin? Most medical historians agree that the first efforts towards answering big clinical questions with analytics were made about 400 years ago in the London Bills of Mortality. These started out in the late 1500s with a somewhat sporadic collection initially of how many citizens within London's walls had died and why. From about 1603 onwards, the bills got into their stride in the form of a weekly report on deaths and later also on births in and then also around London. And these reports were collated every Tuesday, printed every Wednesday, and sold to the public every Thursday from 1603 until the mid-1800s. The method of collecting the data was that after a death was notified, a searcher, or wise woman, would be dispatched to the house of the deceased to establish the cause of death either by inspecting the body or talking to those who witnessed the final illness. Within a few years, an annual report report was also published, collated from the weekly statistics. And the slide shows on the right-hand side the annual report from 1664-65, which demonstrates one of the main reasons the public were interested at all in buying the weekly reports: to get early warnings of whether the incidence of plague was going up or down. Those who could leave town would when plague was on the rise. The accurate reporting of the quantity and geographic distribution of births and deaths in and around London gradually found other novel uses. For example, it allowed the first estimate of London's total population and the rate it was growing at, which helped to inform some of the planning around its expansion. And it also provided the source material for John Graunt's seminal 1662 work, which gave birth essentially to what we now know as the disciplines of public health, epidemiology and actuarial science. Before long, it's noticeable in the later reports that a relatively stable and fixed list of diseases had been settled upon to choose the diagnosis from, and many of these we would now recognise as being primarily infective in origin, including 3 that we would now understand to be in fact different manifestations of the same disease: King's evil, consumption and phtisic on the 1665 annual report are in fact all forms of tuberculosis. The idea of bills of mortality gradually caught on elsewhere until many other cities, both in the UK and abroad, also published their own bills. Eventually, by the mid-1800s, the benefits of having an internationally agreed standard list of diseases on which to base these reports became widely understood, and so the terminology substantially as used in the final publications of the London Bills in the 1800s was in fact, via the work of William Farr, turned more or less directly into what eventually became ICD version 1. Wind forward 400 years and our clinical documentation and our diagnostic tools have grown vastly richer, as has the range of options and guidance on how best to deal with it. So on the left of the slide we have a stack of paper which is one doctor's clinic, diabetic clinic around 2003, and on the right hand side from almost a decade earlier a pile of paper on a general practitioner's desk that outlined all the guidelines they were supposed to comply with. And so even today, particularly in a hospital setting, the cognitive task for clinicians is to be able to apply all the information on the right-hand stack of paper to all the information on the left-hand stack of paper in real time without making any mistakes. Our technical approach to analytics has, however, arguably not changed so very much in the same 400 years. This slide, for example, shows the Emergency Department Dataset, or ED Dataset, a coding system devised by the Department of Health in the mid-1980s. The ED Dataset has similar characteristics to the set of diseases available for recording the London Bills. There are 39 top-level categories, including 2 which are really none of the above. Code 38 is diagnosis not classifiable, and 39 nothing abnormal detected. And these options are to be represented as a 2-digit code. Some, however, are obviously combined categories. So, for example, 05 on screen is dislocation or fracture or joint injury or amputation. And so, in fact, a 3rd digit exists that allows you to distinguish between these. So 051 is dislocation and 052 is fracture, and so on. There is no code 012 or 013, for example, it's just code 010. At the 3-digit code level, there are therefore 67 major types of pathology recognised as something that could present to an A&E department, and this compares with 63 diagnostic options in the London Bills. These 67 pathologies can, however, be further qualified using the ED dataset with an additional 3-digit code, which specifies one of 35 anatomical sites of occurrence, plus the final digit for left or right. And this makes a final ED diagnostic code of 6 digits altogether, first 3 being the pathology and the last 3 being the site. There are therefore roughly 600 clinically plausible combinations of the first 3-digit pathology code with the final 3-digit site code. The ED coding system outlined was in fact a mandatory data collection from all NHS A&E departments from the mid-1980s when it was devised until its eventual replacement by a technically not entirely dissimilar emergency care dataset from around 2017. It therefore formed the foundation of all central efforts to monitor and understand the caseload that falls upon A&E units until very recently. The graph on this slide comes from the Royal College of Emergency Medicine's own website in 2015 and shows how the caseload of presentations to A&E departments across the country had changed during the period of 1987 to around 2010-11. On the slide, an overall 60% increase in patient volumes can be seen, but almost all of that had in fact occurred in the latter part of the period covered since 2003. The note that went with the graph says a large increase in workload, both absolute patient numbers and case complexity, has obviously occurred. But due to poor quality information, in other words, despite the ED dataset, we don't know why this increase has occurred. Meanwhile, over the same period of time, ambitions for what we hope to get out of all the electronic data we're collecting have expanded, with data now required to support a variety of clinical decisions at many levels, from population science and resource planning down to individual patient treatment decisions, risk stratification, care pathway monitoring, and so on. As our requirement for all this data, and particularly for machine processable data, has increased, so we have begun to change how we capture clinical information. We are still working hard to dispense with the tower of paper that we saw in the earlier photograph, and hoping to replace it with, well, possibly a virtual tower of paper. It therefore seems likely that some other things are going to have to change before we're able to both efficiently acquire and then use clinical data. In all other data-rich environments, it's a received wisdom that unless those directly entering data have a reason to also directly use and benefit from it, then the quality of that data will typically be rather poor. But in the clinical world, and especially in secondary care, it's not clear that clinicians either can or want to be so directly involved in interacting with their data. The CDAT project was therefore conceived as something of an experiment of opportunity to explore further what scope there might be for changing that situation. As previously outlined, the original project planned to find some willing clinicians, lend them an encrypted laptop, negotiate with the local ICT department to obtain a bite-sized extract of just that clinician's clinic or service data from the full majesty of the complete enterprise EPR and put that on the laptop, train the clinician to use the CDAT application and enable them to spend a few weeks first of all repairing their data, which is a step we won't be looking at in the workshops, and then once the data is maximally repaired, to craft and run queries over the repaired data to generate graphs and hopefully some clinical insight, and then invite the clinicians to engage with us to share their thoughts on the experience. The topics that the original project sought to investigate and which the continuing project workshops still hope to stimulate thinking about revolve around a central question. Could clinicians practically be enabled to directly analyse their own data to seek the clinical or service insights within? And if they could be, should they? Or is this in fact a better use of somebody else's time? And even if they could, and even should, would they? However, in addition to thoughts on this central question, we're also interested in thoughts on any of the following related topics. Data quality, we mentioned that in the original experiment, the plan had been to encourage clinicians to look at the quality of their data and find ways to repair it before they analysed it. And although the data set used in the workshops has already been through some data repair, it's very likely that some issues of data quality will be experienced. For example, the fact that the code soft tissue injury is by far and away the single most popular code might raise some eyebrows. It doesn't tell us the mechanism of injury or its anatomical location, We might conjecture that it's usually used for trivial soft tissue injury, but we don't know how to prove that hypothesis. We're interested in thoughts on the compute performance and the immediacy of experience. One of the participants in some of the earlier workshops noted that they consider themselves to have a particularly close relationship with their ICT department, as a result of which, if they came up with a clinical hypothesis that might be supported by some data analysis, they considered themselves lucky. They could get the answer in as little as a week. They knew colleagues in other trusts with a less working relationship with their ICT departments, where the same question might take a month or more to get a response. In these sorts of environments, when you find out that the question you asked either was the wrong question or invites a follow-up question, iterating through that process, where you can only do one query a week or a month, is not an attractive process. The desktop analytics offered here would enable you to iterate in a matter of a few minutes. We're also interested in questions to do with coding in general. The data set being demonstrated in the workshops is based fundamentally on SNOMED, but many of the issues that the experience raises are not specific to SNOMED. We're interested in exploring a little further where the responsibility and appetite for analytics in general and desktop clinical analytics in particular might lie. As we've already said, suppliers into this space are interested to know what kind of questions clinicians want to ask, but we're also wondering whose job is it to at least come up with hypotheses that might be requiring more detailed and statistically robust analysis by non-clinicians. But if the initial hypothesis generation is a clinical task because they understand most intimately the nature of the specialty and the local service, then perhaps they still need to get involved with their data. But ultimately, whose job is it to find the answers and also to produce the questions that need answering? The application itself is written in a fairly clunky user interface. Make no particular apologies for that. It was an experimental opportunity, but some people might particularly hate or particularly like some aspects of it, and that's worth capturing. Or indeed anything else that you feel motivated to produce as a result of the session in the workshops. The data used in the workshops and exposed via the CDAT application is real clinical data obtained from one inner-city A&E department. It covers almost 900,000 consecutive attendances made by about 466,000 individual patients at that department over a 6.5-year period to February 2015. Before an attendance at this unit can be completed, so usually before the patient is either admitted or discharged, a single SNOMED CT code must be selected by the treating clinician, doctor or nurse, in order to explain the reason for that attendance. So it's similar in purpose to the ED Dataset, but with tens of thousands rather than only a few hundred codes to choose from. And over the 6.5 years spanned by the dataset, just over 18,000 individual SNOMED codes from possibly 200,000 or 300,000 available were selected at least once, but some of them many times more than once. The runaway winner most popular code, in fact, was 2820260002, soft tissue injury, which single-handedly accounts for 4% of all attendances, so 1 in every 25, and this is closely followed by 215222001, abdominal pain, which accounts for another 2.6% of those 900,000 attendances. Data is rarely perfect, however, and the dataset has one obvious data quality issue, which is that, on average, slightly more than 1 in every 50 attendances has no associated diagnostic code assigned to it at all. We know when it happened and the age of the patient, but not why. And this uncoded attendance phenomenon isn't evenly distributed over time. As the graph on this slide shows, there was a spike during 2012. This is mentioned now because, depending on the particular question that you ask in the workshop, this particular data quality issue could produce misleadingly interesting-looking kinks and bumps in some of the time trend charts that you may get out of the CDAT application. This graph, for example, plots the number of patients attending month by month for any diagnostic reason at all, including for no known reason. The smooth moving average solid line in the background without the squares on it shows an obvious seasonal variation, although interestingly attendance is actually higher in the summer months than it is in winter, because numerically the summertime increase in activity-related, but often trivial trauma, overwhelms the increase in much more complex respiratory illness for which winter is more infamous. But this graph also shows clearly a similar relentlessly upward trend in the total volumes of patients attending month on month, similar to that seen earlier in the national data chart from the Royal College of Emergency Medicine website. By the end of the 6 years, monthly volumes were 30% higher on average than at the start. And another obvious feature of the graph is the rather above average trend, rapid rise in caseload that occurred around 2012. So in other words, during the same period of time when we know the data includes a higher proportion of attendances with no stated diagnostic code. These two phenomena are probably, however, unrelated. The increase seen in 2012 in the absolute count of patients is in fact most likely the direct result of a city-wide change in how acute stroke was managed that involved all cases being consolidated into a small number of hub hospitals, of which this A&E unit was one. The back-end electronic patient record model that supports the CDAT application, if model itself isn't too generous a word to use, is in fact a single table with just a few mandatory and some optional fields as outlined on this slide and also in documentation that ships with the software itself. There is one row in the table per attendance or other clinical event, and each row records only the who, so the patient's unique ID, date of birth, sex and ethnicity, the when, the time and date of the attendance, and the what, in this case a diagnostic code. There's therefore no link to laboratory or prescribing data or other information that would be in a full electronic patient record. However, within the limits of this ultra-simplistic epidemiological model, which is itself thus barely more sophisticated than that underpinning the London Bills, it is still possible to ask some clinically interesting questions using the schema-CT coding and get some answers in the form of graphs. Additionally, it should be possible to see how this basic code-driven search function, demonstrated by CDAT, could, when run over a richer electronic patient model that included numeric searches over lab data, for example, and temporal searches to ask how many patients had one phenomenon followed at some later interval by another, answer more sophisticated clinical questions. The CDAT application will present most of its query results in the form of graphs, a selection of the range of graphs available being shown on this slide. In fact, these graphs are also derived from the data that the workshop uses. So at top left is a chart showing the total number of patients attending on each day of the week for any diagnostic reason, including not coded, and across the entire 6.5 years. You can see from this that Mondays are the most popular and weekends on the whole the less popular days on which to attend. At bottom left is a chart showing the total number attending for any reason but by hour of the day, and this is a pattern very familiar to anybody who has worked in an A&E setting. Bottom right is a graph showing a standard age distribution and age-sex distribution chart. It's clinically interesting because by comparison with the age-sex distribution for the entire national population, which is shown in the small inset graph, the youthfully careless 20 to 30 age cohort are rather overrepresented in the subpopulation of people who attend an A&E department. Probably no surprise there. But the only marginally more cautious 10 to 20 population are perhaps more surprisingly apparently underrepresented in A&E attenders. Finally, at top right is the graph that sort of started it all. This is a scatter plot where each attendance is plotted with the date of the attendance horizontally and age of the patient on that day vertically. A clinician working at the same trust the data comes from remarked that in their clinical experience, patients with sickle cell disease tended to stop presenting to them as emergencies via the A&E department once they got much older than their mid-20s, and they wondered whether the data collected to date by the A&E department would support that hypothesis, that how sickle cell sufferers use health resources has some undocumented characteristic. A query was therefore constructed using the CDAT application to identify 43 SNOMED codes that unambiguously indicate the diagnosis of sickle cell disease or some complication of it as the reason for the attendance, and of the 888,000 attendances in the data over the 6.5 years, only 3,705 were found that had used one of those 43 codes. The chart on this slide therefore plots each of these 3,705 attendances by date and age of the patient. Although not an entirely statistically robust methodology, a simple visual inspection of this plot strongly suggests the clinician was right. Most of the attendances do seem to be clustered below the age 30 line. And the plot also reveals two other characteristics. Firstly, the parallel but gently upwardly sloping series of closely spaced dots represent the frequent attenders in this cohort. The lines are sloping because the patients are just a little bit older each time they re-attend. But it's noticeable that the frequent attendance phenomenon appears to be clustered within the 20 to 30 age cohort. Secondly, sickle cell crisis events are, at least according to the textbooks, classically especially likely to occur during cold weather, and the blue bars in the background of the slide correspond to the cold months of the year from November through till March-April. But the data doesn't obviously support this still being a significant factor in when sickle cell crisis occurs, despite a couple of the later winters on this chart especially having been unusually cold even for the UK. There's no visible vertical band within the scatter plot, such as we might expect to see if events were clustered inside the cold blue bars rather than outside them during the summer months. During the main hands-on part of the workshop, you'll be able to use the CDAT application to interrogate the same dataset to generate similar graphs, asking questions of clinical interest yourself, at least within the limits of the sparse dataset and the querying tool itself, and then see your results displayed similarly as graphical outputs. And so finally, to the CDAT application itself and a quick introduction to its user interface. Most of the time during the workshops you'll be spending going backwards and forwards between just two of CDAT's screens, the Query Builder and the Query Runner interfaces. This slide and the next provide a basic orientation to each. The Query Builder screen is divided into four obvious panes. The left one, currently highlighted with yellow, shows a list of pre-existing query definitions that you can choose from and either edit or extend or just see how they're put together. Each individual query definition is made up of any number of clauses. The query is displaying at the moment is in fact not a SNOMED one, it's been authored in Clinical Terms version 3, which is also supported by the CDAT editor. On the right-hand side are a number of results. Typically when you search for something, you type into the yellow pane across the middle the word or words you want to search for to find matching codes, for example, and those results would appear in that right-hand pane, but other results for other sorts of questions that can be run while building a query would also appear over there. And finally, when you click on codes that appear in the various parts of the interface, there'll be a hierarchy browser showing where that particular code sits within the terminology it belongs to. So in the screenshot at the moment, the hierarchy display is showing where H33 ... appears in the Clinical Terms version 3 taxonomy. There are a number of buttons around the screen to click on to either add or remove clauses from individual cluster definitions, or in fact to move entire cluster definitions around, and exactly how they work will be made clear during the hands-on session. The Query Runner screen is similarly divided. Currently displaying in yellow is the EPR for one patient, which is formed by recovering each row in the impoverished EPR table for each episode of care or each attendance that they've had, and just listing them in date order. There's a list of queries that can be used and combined, and these are partly derived from the queries that have been built on the query builder. So all those prefixed with Q will correspond to some query that is currently displaying in the builder screen, and those can be combined with demographic properties like age cohorts, sex of the patient, ethnicity, and other characteristics that are not to do with the coded components of each row in the data table, but other aspects of it which can be queried independently, in combination, or in combination with a code-driven query element. On the far right-hand side, a variety of results will appear, and that will make more sense when it's used live. And as we've seen before, there are a number of graph outputs that are produced. So thanks very much for watching. We look forward to seeing you at the hands-on workshop if you're registered, or if you're viewing this as a standalone presentation. I hope you found it useful. The CDAT application, also called, or more commonly called, the Data Migration Workbench, is unsupported open source freeware written in Microsoft Visual Basic. Requires Microsoft Access to run, and it's available for free with registration from the website below there. And if you can't find that, you can also search TRUD DMWB on Google, and usually the top hit will be the link to take you to the place that you need to go to download or register and then download for the application. So thanks very much, and see you soon.